Okay, so a couple of things real quickly as I switch my recording here. We need to understand that we are winding down for the semester. This is going to be the next to last class that we'll have. Our last session will be the one that we have on Thursday when we wrap up things for this course. We just finished test number 5, and I want to go over that real quickly. For test number 5, the average was 93. You guys did a relatively good job again. Standard deviation of 2.23 points. The average time taking the test was 35 minutes and 37 seconds. And there were approximately, I think, 20 or so test takers. There are only a couple of things I wanted to clarify for the exam that we just finished, and that is one of the items that said, as which of the following theorists described personality in terms of fundamental traits? And some of you answered Freud, I think, and some other few people, but the individual who's credited for that is Gordon Allport. He's the one who focused on these fundamental traits. Also, there was another item on the DSM-5, the diagnostic criteria and codes. They resemble the World Health Organization's international classification of diseases. Okay, so those were the two items I wanted to make sure that we had some clarification on. And again, that means that less than 70% people got those correct. Okay. Now, the other thing I want to make a really brief comment on were the paper assignments. All of those have been graded, the ones that were turned in. Also, I want to note that I want to emphasize what the purpose of this activity was, and most people did relatively well on them. I think the average was around 92, 93 actually. But basically the idea for these assignments, again, was for you to get some familiarity with reading an article, trying to paraphrase that article and cite it appropriately, citing with the appropriate reference associated with it. And those of you who continue into psychology, you'll be doing much more of that as you go with other classes beyond Psych 210. Now, so that's where we are so far. And so we're going to pick up the next unit, the last unit, unit 6 here, starting off with the conversation about therapy. Now, therapy is going to be the first really applied psychological area that we're going to be focusing on. Everything else, had some applied aspects to it to some degree, but therapy is usually what we think of when we talk about applied psychology, how we apply to help other people. So that's what we mean here by looking at therapy. For an overview of this particular chapter, therapy refers to how mental disorders are treated with the help of knowledge base of psychology. Topics that we'll be covering will be the following: psychotherapy, the talk therapies, issues in psychotherapy, biomedical therapies as well, and the prevention of psychological disorders. When we look at these last two, we'll be looking at that in the next session, the last session we do this week. So the psychological therapies: improving treatment of mental illness. We'll be looking at the psychoanalytic and psychodynamic therapies, humanistic therapies, behavior and cognitive therapies, group therapy, as well as family therapy, as we look over the information for this particular chapter this week. So first, some of you may recall that in the first few pages of this chapter, there's an individual that you're introduced to called Kate Jamison, and you look at her case of what she's going through with regard to some psychological issues that she's experiencing. And so what we want to do is, what is the issue that she has? What benefits did her therapist provide her? And so this gives you sort of an idea of what therapy can do and how it can sort of assist people. Just to go ahead and give you the short skinny of this, Kay Jamison suffered from bipolar disorder and periods of depression and mania. Okay, and these quotes here sort of reveal the therapist's commitment, concern, understanding, and tough confrontation when needed helped her becoming and staying mentally healthy. So she would say, he saw me through madness and despair. Oftentimes when someone is going through some issues, it's always good to have somebody that is there to help you weather the storm. He was tough and very kind. Again, sometimes you have to be somewhat confrontational doing therapy to make sure people understand what's going on and don't sell themselves short by cutting slack to themselves when it's not really appropriate thing to do. He understood more than anyone else. He taught me about the mind and brain, and also you learn about your particular situation, but you also take it as an educational opportunity as well to learn about how the mind and brain work in concert with one another. And then one of the key things here that we see is that psychotherapy heals. So the notion is, when we look at the therapies that we go through, realize that these are tools to aid people to get mentally healthy. And we'll see as we go through the variety of therapies out there, there's not one way of therapy that fits everyone. And so depending on what the situation is, what your psychological issues may be, as well as who you are as an individual, that also may indicate what types of therapy may be best for that particular individual. So first, we'll start off by going back in time a little bit and looking at the historical treatments to people with psychological disorders, to treat mental illness. And of course, we did cover some of these ideas in the previous session on psychological disorders. So in the history of mental health treatment, when people have displayed unusual behaviors rooted in the mind, these people have often been locked away or treated using old ideas of mental illness. For example, they would have beaten them out of people, like evil spirits. You beat it out of them, or you get leeches to suck blood, to bleed them, or cut them to bleed them out. Okay, or you would do, as we see here in this image, drill holes in the skull to let the spirits out, the evil spirits. Now, obviously, fortunately, this was not the way we continue to see how to treat people with mental issues or psychological disorders. So we did see and move away from those type of treatments. The treatments may not seem very positive to you, but at one point they designed this chair, I think it's by the name Benjamin Rush, I believe, designed a chair to be an improvement in medical treatment. It was meant to have a calming effect on the people with mania. So they would have them strapped down here with the box over their head here. Now, the idea is, how could this possibly be something that would be beneficial? Well, what it comes down to, the notion is this was one way of treatment. The other way would be trephination, where they would drill holes in people's skulls. So obviously, compared to trephination, this is most definitely a step up. But also, some people with autism find firm restraint to be dramatically soothing when they are overwhelmed with stress. So to be held or to be constrained some way. So we do see, depending on what the issue is, this thing could be very effective for some. Other forms in treatment involve seeing the insane as ill instead of being possessed, treating them with tenderness and not harshness, housing them in hospitals rather than locking them up in those asylums that sometimes the middle and upper middle class or the upper class would go visit like they were going to a zoo, and developing psychotherapeutic treatments, medications, and community supports to allow life outside of hospitals. So we saw these reforms as being very instrumental, leading to the more modern ways and modern treatments for people who have psychological disorders. I'm going to pause real briefly here to see if there are any questions or comments at this time. I know I've just jumped into it. All right, everybody seems okay? All right, so let's start looking at some of the modern treatments of people with psychological disorders, looking at how therapy sort of evolves. So the current forms of therapy fall into two broad categories. We have psychotherapy and biomedical therapy. With psychotherapy, it's an interactive experience with a trained professional working on understanding and changing behavior, thinking, relationships, and emotions. So that is a very broad definition of psychotherapy, but it includes an aspect of all the types of therapies that we'll be looking at today. And then we have biomedical therapy, the use of medications and other procedures acting directly on the body to reduce the symptoms of mental disorders. And we'll see a little bit more of that in our next session when we get together. Now, we also have another approach which combines these types of therapies here. An eclectic approach uses techniques from various forms of therapy to fit the client's problems, strengths, and preferences. So not all clients are the same, and therefore there may be a eclectic approach that you design just specifically for a particular client to get them through their problems. In addition, we have medications. Medications in conjunction with psychotherapy can be used to be very, very effective. They help each other achieve a better reduction in their symptoms. So the schools of psychotherapy, the modern treatment. So let's look at these real quickly here. We have psychoanalysis, psychodynamic therapy, which is what Sigmund Freud's sort of started, and is the legacy that he started out with, and we still see that today. People are utilizing psychoanalysis as well as psychodynamic therapy. We have humanistic and client-centered therapy. That's started off by Carl Rogers and Abraham Maslow. Behavior therapy using conditioning, and again, this is based on the work of B.F. Skinner and Ivan Pavlov applied to people. So those things that we learned in the learning chapter applied those to people to try to change their behaviors. And then cognitive therapy and changing thoughts. Aaron Beck and Albert Ellis, reducing errors in distress with the way you think, how you think things through, how you judge the things and events around you. So let's look first at psychoanalysis. The goal of psychoanalysis is to release the tension of repression and resolving unconscious inner conflicts. So remember, the key thing that Freud looked at was this notion of the role of the unconscious. And so his psychoanalysis has a large part of it involves the unconscious conflicts, the things going on, the unresolved issues and conflicts going on at a level of awareness that you don't have. You're not aware of this necessarily. So psychoanalysis, Sigmund Freud believed that many people have anxiety related to id, ego, superego conflicts, okay, such as repression of sexual wishes. The techniques of psychoanalysis, he used free association. The patient speaks freely about memories and dreams and feelings. And then interpretation, where the therapist suggests unconscious meanings and underlying wishes to help the client gain insight and release the tension. Now let's look at the photograph here. In photograph here, if you can make it out on your screen, you have a green chair on the left, and then you have this little couch type thing with a little blanket over it and some pillows. And that's where the client would sort of lay down there, facing away from the therapist. And the reason why they would do that is that they want to make sure that the patient was uninhibited. So if you have to look at somebody as you're sort of releasing all this stuff of what's going on in your mind and all this type of stuff, you may be somewhat hesitant. So they want to be uninhibited. Therefore, they had the patient looking away so they wouldn't be distracted by the therapist or Freud, and more likely to transfer onto the therapist feelings associated with past people. So again, it was a looking away from the therapist. The therapist is sort of like a voice in the background and not seeing this individual, and that would make you a little bit more free to unburden yourself and not be so hesitant. So when it comes to the interpretation in psychoanalysis, the therapist may see unconscious meaning in the client's resistance, dreams, and transference. Resistance, the therapist notices times when the patient seems blocked in speaking about certain subjects. So you can see the subject is always changing the topic when it gets to a certain subject, or not answering the questions directly. And that would be signs of resistance. And that would be something that would pique the curiosity of the therapist to try to find out what's going on there. And then there are dreams. There may be themes or latent content behind the plot of a patient's dream. So as they tell you the dream, you're looking for the subplot, the real underlying latent meaning of that dream. And then there's transference. The patient may have reactions toward the therapist that are actually based on feelings towards someone from the past. So as they are interpreting things, they're looking at the resistance, dreams, and potential transference to try to uncover those unconscious things that are going on in the patient's mind. Then we have psychodynamic therapy. So we just looked at psychoanalysis and now psychodynamic therapy. Psychodynamic therapy is derived from the psychoanalytic tradition that we just saw, but compared to psychoanalysis is somewhat different. Fewer sessions per week and fewer years. So with psychoanalysis, you see someone several times a week and it can last for decades. With psychodynamic therapy, there are fewer sessions per week and it lasts much shorter than psychoanalysis. There's less theory about sex, id, and superego in psychodynamic therapy. The client now faces the therapist and focuses on the present, not just the past, as we saw in psychoanalysis. The therapists help reveal and resolve the dynamics, the forces, and changes in the individual. The focus is on improved self-awareness and insight into unconscious thoughts and feelings, which may be rooted in past relationships. In addition to insight, therapists suggest changes in patterns of thinking and relating to others. For example, a man who could not feel love because he felt it was not manly, he could resolve this tension and risk feeling love. So the idea here is that they're focused more on the present, not just the past, as we saw with psychoanalysis, where everything is past, something that's happened a long time ago, and you're unrooting it from the unconscious to get some sort of relief. Here, the focus is not just on that past, but on the present as well. Now, in opposition to that, we have the humanistic therapists. Remember, the whole movement of humanism in psychology came up as a reaction to the coldness, they thought, of the psychoanalytic psychoanalysis that Freud came up with, as well as the coldness they saw too, the unhuman aspects of just controlling people's behavior that the behaviors came up with. So the humanistic psychology, with Abraham Maslow and Carl Rogers being the major proponents, emphasizes the human potential for growth, self-actualization, and personal fulfillment. So in humanistic therapy, they attempt to support personal growth by helping people gain self-awareness and self-acceptance. So we see this idea of becoming more aware of who you are and what you are about, and becoming more accepting of who we are, even if there are things in there that we may not even like about ourselves. Now, the primary therapy was client-centered therapy. It's what Carl Rogers named his particular humanistic style of therapy. Now, let's compare the two, humanistic versus psychoanalytic therapy. Both therapies seek to promote insight, but here are some differences. First, let's look at the goal. Humanistic psychotherapy, their goal was to promote growth, whereas with the psychoanalytic, it was to cure mental illness. The humanistic psychotherapy saw how to improve. They wanted to take responsibility for feelings and actions and accept oneself. Whereas in the psychoanalytic tradition, they wanted to improve by bringing unconscious conflicts into conscious awareness. So unrooting those things in your unconscious. So now you have awareness of them. The role of the therapist in a humanistic approach is to provide an environment in which growth can occur. The therapist and psychoanalytic tradition provide those interpretations, for example, of dreams, resistance, and transference. So you bring those things up when the patient or the client is resisting, or you interpret their dreams or their transference. Then we have the content of therapy and the humanistic tradition. The content of therapy is conscious feelings, the actual self, and the ideal self. Two ideas that we discussed previously in the session just before this one. So with content of therapy, the humanistic wanted to see your conscious feelings and look at the actual self and your ideal self. Whereas in the psychoanalytic tradition, it was looking at the unconscious conflicts. And then the time focus. The humanistic psychotherapy approach to time is the present and the future, whereas with the psychoanalytic approach, again, it's looking at the past, how the past has influence going on today. So let's look at the client-centered therapist approach. So in the style of client-centered therapists, they want to be non-directive, genuine, accepting and showing unconditional positive regard, and empathic. Okay, so that's the characteristics they want these therapists to have. So being non-directive, let insight and goals come from the client rather than dictating interpretation. So whereas the psychoanalyst interprets for the client, here insight and goals come from the client, not the therapist. Then be genuine. Be yourself and truthful. Don't put on the therapist facade. So the idea is you're sort of, in a client-centered therapist, you're sort of establishing a certain type of truthful relationship with the client here. And so you don't put on the face of just the unemotional type of therapist. So here, be yourself, be truthful, and don't put on the therapist facade. Being accepting and showing unconditional positive regard. Help the client learn to accept themselves despite any weaknesses. So there could be something that you don't like about yourself. Here, the therapist tries to get the client to accept who they are, despite the weaknesses that they may have. And be empathic. Demonstrate careful attention to the client's feelings, partly by reflecting what you hear the client saying. Now, we talked about this briefly before, that communication is a very important aspect of this type of therapy, particularly active listening. And we talked about active listening before as well. And active listening, okay, you show empathy through active listening. You demonstrate to somebody that you're communicating with that you are truly listening to what they are saying. So client-centered therapists show that they are tuning in to clients' feelings and meanings. They do this by summarizing and paraphrasing. So your father wasn't around much. So that's asking a question, trying to summarize and paraphrase what the client has just communicated to you. You summarize and paraphrase. So your father wasn't around much. 2, you invite clarification and elaboration. For example, when you say anxiety, what does that feel like to you? What is going on in your body and thoughts? So here you're asking them to be very clear and more specific on clarifying what they are meaning. And then 3, reflect feelings. It seems like you are disappointed. Am I right? And so the idea here, you're not putting words in their mouths here. You're trying to elicit the correct information. So, for example, let's say you're discussing something with a friend and the friend just says, "You're upset with me." Okay. You might not be upset with them, but he put that on you. But the reflecting of feelings is you trying to get at the truth. So it seems to me that you're upset. Is that right? So they're asking the question, they're reflecting feelings to try to see if they are correct and what they are assessing from you as a friend, but also here in a therapeutic situation, they're reflecting feelings. Is it truly disappointment that they're feeling? If not, the client can then correct the therapist on that. All right, any questions or comments so far? Okay. So when it comes to behavior therapy, with behavior therapy, sometimes insight that we see from the other forms of therapy is not helpful to recover from some sort of mental health problem. The client might not know the right changes to make, but finds that it's hard to change actual behavior. So now we can look at behavior therapy, and it uses the principles of learning, especially those of classical and operant conditioning, to help reduce unwanted responses or behaviors. These might include behaviors such as addictions or emotions such as panic. So that's what we use with behavior therapy. We use all that stuff that we talked about in the chapter on learning in ways to aid people in changing their behaviors that they don't want. So one way that we can look at it is through classical conditioning techniques. For example, something referred to as counter conditioning. It refers to linking new positive responses to previously aversive stimuli. So you have, for example, here, if you have been conditioned to fear stores because you've had panic attacks there, you could be led into a store and then helped with relaxation exercises. Okay. The goal is to associate stores with relaxation, a state incompatible with fear. So what you're doing is you're trying to link new positive responses to the store, responses that are incompatible with the ones that you have initially, fear. So that's what we mean by counter conditioning and how we can use that technique that we learned in the previous chapter to try to help a patient out. Then there's exposure therapy. A conditioned fear can worsen when avoidance of the fear situation gets reinforced by a quick reduction in anxiety. So remember the different forms of learning that we talked about. So if you have a fear and then you avoid that fear, the fear stimulus is there, you avoid it, and then you get reinforced because the anxiety gets reduced, then that's just going to make the fear all the more powerful. That's what we learned in the previous chapter, that we are reinforcing and making that behavior more likely to occur in the future. So we don't want that to happen. So we do what is referred to as guided exposure. Guided exposure to the fear situation can reverse this reinforcement by waiting for the anxiety to subside during the exposure. So you guide them to the fear and wait for the fear, anxiety to subside. This is exposure therapy. Now, the person can habituate, that is, get used to the anxiety itself and then the feared situation. It takes time as we go through this sort of exposure routine. Now, in this somewhat funny cartoon here at the very bottom of the caption, we see Professor Gallagher and this controversial technique of simultaneously confronting the fear of heights, snakes, and the dark. So they put a man, and this would be way too much, in a high little container. So that's the fear of heights. We also have the dark. He's in a darkened room, and we have snakes in there as well. So he's doing way too much at one time. So this person has not a chance. But we could do something called systemic desensitization. Might have been more effective technique to employ. And what that is primarily is a version of exposure therapy. Sometimes exposure to the fear situation is too anxiety provoking or impractical. In those cases, we can use systematic desensitization, beginning with a tiny reminder of the fear situation. So something that is not too frightening, but is something associated with the fear, and keep increasing the exposure intensity as the person learns to tolerate the previous level. So you get them used to experiencing the feelings at the low level, and then you increase to the next level, and then the next level, with them learning to tolerate it at each level. that is systemic desensitization. Then we have virtual reality therapy. This involves exposure to simulations such as flying or snakes. For example, let's say it may be a little bit too dangerous to expose somebody in a particular situation, so you give them a virtual reality therapy or a virtual simulation, a simulation of it, so that they can experience it without having too much of a risk there. So the notion is, obviously, as we look at all these different types of therapists, there are going to be situations where you may feel more comfortable with one type of therapist or another. And this is going to be totally up to the individual who's seeking some sort of help. But obviously, there are going to be things too that we'll be looking for in a therapist that we'll talk about a little bit later that are going to be key as well. Now, we also have another type of conditioning called aversive conditioning. When a person has been conditioned to have a positive association with a drug, for example. So we have someone who has a problem drinking alcohol, all right? So what we want to have is we want to have a substance that causes us to be nauseated or sick in a way when we have alcohol in our system. So what we do is we have alcohol serve as the neutral stimulus, okay? Then we put in the alcohol a drug, or they take a drug, and so when alcohol and the drug are combined, it makes them nauseated. Okay, they have nausea. So then eventually the smell, the taste of alcohol itself causes the nausea. And this is aversive conditioning, where we can associate the drug with a negative response. So the idea of the drug here is going to be the alcohol, and we want them to see the alcohol as something that is unpleasant or causes them to be nauseated. Now, operant conditioning therapy. Operant conditioning is the shaping of chosen behavior in response to consequences of the behavior. So this is the work of B.F. Skinner. Behavior modification refers to shaping a client's chosen behavior to look more like a desired behavior by making sure that desired behaviors are rewarded, problematic behaviors are unrewarded or punished. So here we go. Applied behavioral analysis is used with nonverbal children with autism. It rewards behaviors such as sitting with someone or making eye contact, so they get rewards for that, and sometimes punishes self-harming behavior. So it does something, when they do something that is self-harming, they get punished in some manner in order to stop that behavior. We also see token economies. Let's say you are working at a mental institute, a facility where you have people who are, let's say they're housed there, they live there, and you want to be able to use more operant conditioning to try to modify their behavior. The way you can do that is to establish a token economy. A token economy uses coins, stars, or other indirect rewards or tokens. So now these things can have value to them. They can be collected and traded later for real rewards, like more time at play or chocolate candy or some other toys or comic books or something of that nature. So basically think of token economies as sort of like money inside an institute. Now, what they're doing that for is this. If you have token economy, you have these tokens, then you can modify their behavior by controlling the circumstances in which they can get more tokens or have the tokens taken away. If they misbehave during a particular class, they get tokens taken away. If they behave during a particular class, they get tokens added to their pool. So in this way, they have added an economy that they can control by adding or taking away the tokens. So this way, it gives them a way in order to further modify the behavior of people in this particular facility. Now, there are plenty of critiques to behavior therapy. Does it work? And when it does, do the changes stick without insights and other changes to hold the new behavior in place? Well, it does often work, but extinguished behaviors and reactions do spontaneously reappear. And we've talked about spontaneous recovery before. And so this is the real life action of that, where a behavior can reappear. To ensure maintenance of changes, a transition is needed from artificial rewards to awareness of the natural environmental consequences. So you have to get them off of utilizing the artificial rewards, the extrinsic factors for the change in behavior, so that it can become more intrinsic to them. It becomes part of their repertoire, so to speak. So is it ethical? Since conditioning operates below conscious awareness, couldn't people's choices and reactions be manipulated without their consent? Well, to minimize that particular ethical problem, remember, when we talk about conditioning is being processed at various levels, but one of the levels is at the level of the cerebellum, and that's where conditioning lies. And the thing about it is, we're not usually going to be always aware of that. So to minimize ethical problems, we need to acquire consent, at least of the guardian. So if we're talking about a young person, we may have to get consent to do the conditioning from the parent or the legal guardians. Then we want to develop goals for treatment that are more humane than the alternative. For example, shaping autistic behavior is seemingly better than institutionalization. So if you have a choice between shaping someone's autistic behavior or having them sent off to live in an institution, then of course shaping behavior is going to be much better than sending them off to be institutionalized. So that's the way we sort of address the ethical concerns, which there are some ethical concerns there. Then we have cognitive therapies. Being depressed and or anxious involves negative thoughts and interpretations. So here we have an incident, an event occurs, like a lost job. And then you have your internal beliefs. If your internal beliefs is, I'm worthless, it's hopeless, that type of internal belief and interpretation of events may lead to depression. If the same event occurs, but your internal beliefs are, my boss is a jerk, I deserve something better, that most likely will not lead to depression. So in cognitive perspective, the cause of depression are not bad events, but our thoughts about these events. So the chart on this slide just assumes the direction of causation is to the right. In reality, pessimistic cognition can be function of depression. However, even if the depression came first, these negative thoughts and interpretations can make depression worse. So cognitive therapies in practice. Cognitive therapy helps people alter the negative thinking that worsens depression and anxiety. So it helps people alter their negative thinking that worsens depression and anxiety. Therapists might suggest other thoughts that the clients could have about their lives, or at least point out when clients jump to conclusions that make them feel worse. So the schools of cognitive therapy, we have Albert Ellis's rational emotive behavior therapy, challenging irrational beliefs and assumptions. We have Aaron Beck's cognitive therapy for depression, correcting cognitive distortions. We have Donald Minchenbaum's stress inoculation training, practicing healthier thinking before facing a stressor, disappointment, or frustration. So those are some of the schools of the cognitive therapies that are out there. So let's look at Aaron Beck's therapy for depression. Aaron Beck helped people see how their depression was worsened by errors in thinking, such as catastrophizing, interpreting current events as signs of the worst possible outcome. You know, some individuals have that tendency. They think of the worst possible case scenario that could happen. They make a catastrophe out of it. And so what Aaron Beck is trying to do here is, for those individuals who have depression, they want to try to attack this style of thinking. Now that I've made a mistake in my lecture, I failed as a professor. Students can't take me seriously and they can't learn from me. I can tell you how many times I make numerous issues or have many gaffes doing a particular lecture all the time, live in these recorded sessions as well. So the idea is that we can't make a mountain out of a molehill, so to speak, but that can lead to depression when you see everything as a catastrophe. Beck's style of therapy helps clients notice and challenge these errors in thinking. And hopefully you see them too when you may get into that mode of thinking sometimes that you're making too much out of it. Now, here are some cognitive therapy techniques. So below are some general goals and specific strategies used in cognitive therapy. So the aim of the technique: reveal beliefs, question your interpretations. So explore your beliefs, revealing faulty assumptions such as I must be liked by everyone. Rank thoughts and emotions. Gain perspective by ranking your thoughts and emotions from mildly to extremely upsetting. Then test beliefs. Examine the consequences. Explore difficult situations, assessing possible consequences and challenging faulty reasoning. Decatastrophize your thinking. Work the actual worst case scenario consequences of the situation you face. It is often not as bad as you imagine. Then determine how to cope with the real situation you face. Then change your beliefs. Take appropriate responsibility. Challenge total self-blame and negative thinking, noting aspects of which you may be truly responsible, as well as aspects that aren't your responsibility at all. And then resist extremes. Develop new ways of thinking and feeling to replace maladaptive habits. For example, change from thinking I'm a total failure to I got a failing grade on that paper and I can make these changes to succeed next time. So another type of therapy is called cognitive behavioral therapy, CBT. It works to change both your cognitions and behaviors that are part of a mental health disorder. So it's attacking both cognition as well as behavior. Using CBT, people with OCD, obsessive compulsive disorder, are led to resist the urge to act on their compulsions, as well as learn to manage obsessional thinking. Then we have the other types of therapies, like family therapy. Having a session with the whole family at home or in the office allows the therapist to work on the family system. That is, the family's patterns of alliances, authority, and communication. A related modality is couples or marital therapy as well. We have group therapy, assembles about 6 to 9 people with related needs into a group, facilitated by a therapist to work on therapeutic goals together. The benefits include less cost per person, more interaction, feedback, and support. And clients also realize others share their problems and they are not alone. And then we have self-help groups. Self-help groups are led by a group members instead of a therapist. They can be much larger than group therapy with less interaction. And the focus is more on support rather than working on goals during a group session. And we see these can also be like self-help groups as well, social support groups. For example, people who have a particular addiction may get together, like Alcoholics Anonymous, those types of things as well. Now, comparing therapies can be difficult at times, but we want to compare what these therapies have to offer and what types of things that they can be very beneficial to do for us. So we have comparing modern psychotherapists. We have psychodynamic therapy. We have The presumed problem is unconscious conflicts from childhood experiences. We have client-centered, where the problem is barriers to self-understanding and self-acceptance. Behavioral therapy, the problem is dysfunctional behaviors. And cognitive therapy, the problem that is presumed is negative self-defeating thinking. And cognitive behavioral therapy, the presumed problem is self-harmful thoughts and behaviors. And then in group and family therapy, the presumed problem is going to be stressful relationships. The therapy's aim. Psychodynamic aim is to reduce anxiety through self-insight. The aim of client-centered therapy, enable growth via unconditional positive regard, genuineness, and empathy. Behavioral therapy aim, relearn adaptive behaviors and extinguish problem ones. The aim of cognitive therapy, promote healthier thinking and self-talk. Cognitive behavioral therapy aim, promote healthier thinking and adaptive behaviors. And group and family therapy aim, heal relationships. The therapy techniques. In psychodynamic techniques, we have interpret patients' memories and feelings. For client-centered techniques, listen actively and reflect clients' feelings. Behavior techniques, use classical conditioning via exposure or aversion therapy, or operant conditioning as in token economies. The cognitive therapy technique, train people to dispute negative thoughts and attributions. Cognitive behavioral therapy technique, train people to counter self-harmful thoughts and to act out their new ways of thinking. And group and family therapy technique, develop an understanding of family and other social systems, explore roles, and improve communication. We also can do some research of these therapies as well, using research to help ensure effective therapy. We can use client perceptions. Do they feel like they are getting better? Therapist perceptions, do they feel like they're being helpful to their clients? We also have regression to the mean, outcomes, symptom improvement, comparing treatment to no treatment, comparing treatments to each other, matching the treatment to disorder, considering research along with clinical expertise and client characteristics, considering treatments with less research support like EMDR, which we'll talk about a little bit later, as well as light exposure therapy, common elements of effective psychotherapy, culture, gender, and values, preventing disorders. So let's look at some of these now. How do we know if therapy works? Well, there are different measures of the value and the effectiveness of psychotherapy. Whether the client is satisfied is one of them, whether the client senses improvement, and whether the therapist sees improvement as well. Whether there has been an observable, measured change in the initial symptoms. So problems with some measures. If clients perceive an improvement, are they trying to justify time spent on therapy? That could be a possibility. They're spending their money, they should want to hope to see some sort of improvement. If the therapist sees improvement, are they seeing only their good outcomes and ignoring the ones where they're not having success? If research shows good outcomes for most clients, would they have improved anyway? For some disorders, as we've talked about in the previous session, there will be some bounce back to regression of the mean, so to speak, to where they normally are, especially if the stress of some external event caused a deterioration in their mental health. Once that event is over, then they can get back to where they were before. So studying treatment outcomes, to track the effectiveness of an intervention, we use a control group not receiving the intervention, or even a placebo group. To measure effectiveness, we use objective, observable measures of symptoms rather than relying on client or therapist perceptions. Again, this goes back to one of our first conversations in the first part of this course on research methodologies. And so this talks about how it is that we conduct research in these areas that can be trusted. So understanding outcome data. If we find that even people in a control group, for example, on a waiting list to get seen, showed improvement, is therapy a waste of time? So here what we have is this. We see these two curves. We have the untreated person, the average untreated person, and the average psychotherapy client. People are more likely to improve with treatment. So we have poor outcome on the far left end. On the far right end, we have a good outcome. We see the red line here that represents the average psychotherapy client. About 80% of untreated people have poor outcomes than the average treated person. That's what this is showing. So yes, sometimes people will get better on their own, but they tend to get better more rapidly with treatment, and they tend not to fall back into the same issue with treatment as opposed to without. So the average person who's untreated, well, they're not going to have as much success as the person who is treated with psychotherapy. So the outcome data does tend to suggest it's better to get therapy when one is having some issues. Results of outcome research. Which forms of psychotherapy work best? To some extent, it depends on mental health problem being treated. For example, we have depression. Depression seems to be best treated by cognitive behavioral therapy as well as psychodynamic therapy. Anxiety can be done by cognitive behavioral, psychodynamic, and exposure therapy. Phobias, exposure therapy and behavioral conditioning, and bedwetting is most effectively treated by behavioral conditioning. So again, this just points to the idea that with certain types of issues, the type of therapy can be somewhat predetermined based on what the outcome research says about effectiveness. Now, using outcome research in therapy, we have evidence-based practice refers to the use of outcome research about the effectiveness of different techniques to select therapeutic interventions. So here we have clinical decisions are made based on more than just outcome research. We have the clinical decision making is going to be based on a variety of factors. We have patients' values, characteristics, preferences, and circumstances. So this is going to be the individual characteristics of the patient, the clinical expertise of the therapist, and the best available research evidence. So all of these things together can sort of combine to make the appropriate clinical based decision based on the evidence. Now, evaluating alternative therapies. When new cures emerge, they are often promoted with testimonials. The problem with that is we don't know if those cures were really caused by the intervention. In addition, we don't know how many people received no benefit from the intervention. Sometimes when these are alternative therapies, you'll only hear about the successes and not hear about the failures. The solution: conduct controlled studies with random assignment to non-intervention conditions. So the idea here again is that when we have alternative therapies, we need to put them to the test of research, of testing in such a way that we have a better idea of how successful and effective they are compared to just basing it on someone's testimony. The challenge, however, is making sure that interventions are performed by people trained in that particular area. So oftentimes people will tout alternative therapies to things, but you need to know and make sure that they are the proper person with the proper background and the proper training. Now, here are some of those alternative therapies. We have EMDR, which is eye movement desensitization and reprocessing. In EMDR therapy, the therapist attempts to unlock and reprocess previous frozen traumatic memories. The therapist waves a finger or light in front of the eyes of the client in order to integrate past and present and left and right hemispheres. Now, some studies show EMDR is effective and some do not. Studies which do not show effectiveness were critiqued by the founders being done without adequate training in EMDR. Is this a valid critique of the research? Potentially, but research suggests that the effectiveness of EMDR, even when it doesn't work, may not depend on eye movement technique at all. So the key thing to focus on there, what they're trying to do is trying to reprocess previous frozen traumatic memories. So they're trying to address traumatic memories in people's background. Then we have light exposure therapy. Research supports the idea that daily exposure to bright light, especially with a blue tint, is effective in treating the depressive symptoms of seasonal affective disorder. And we talked about this in the previous lecture as well. SAD, again, is something that tends to occur when the days get shorter and we're around darkness much longer. And sometimes people can be improve their situation by having light, like this person here, that sort of mimics the light of the sun. So what do effective psychotherapy styles seem to have in common? So what we tend to see is the following when it comes to effective psychotherapy. Hope. Therapists assume the client has resources that can be used for recovery, and that improvement is possible. A new perspective. New interpretations and narratives from victim to survivor can improve mood and motivate change. The relationship. Empathy, trust, and caring provide an environment for healthy growth. So the idea is that the successful working relationship between therapist and client has been called the therapeutic alliance. Psychotherapy also may offer a safe place to explore feelings and ideas in self, a source of ideas and options for behaving and seeing things differently, exercises in behavioral, cognitive, and emotional change, and an affirmation for who you are, along with support for change, and also a source of a source of challenge and enrichment to support neural growth and integration. Now, last few things as we wrap up today's session. Culture and values in psychotherapy. Therapists differ from clients in beliefs, values, cultural background, conversational style, and personality. Ways to serve diverse clients. You don't have to be the same as your client or you the same as your therapist for you to receive some help. Therapists should be receptive, respectful, curious, and seek understanding rather than assuming it. The therapist and client do not have to have similar backgrounds for effective therapy and a good therapeutic relationship. It is more important to have similar ideas about the function and style of therapy. And then when selecting a therapist, how do you choose a psychotherapist? Well, specific training and experience in the area of your difficulty may be more important than the general type of license. And what is most important is whether you and the therapist are able to establish that alliance. Some of this is trial and error. If problems arise, you can try working it out, but switching therapists is okay. Therapists in their very training. A couple of ideas here, a couple of facts for you. Psychotherapist does not necessarily equal psychologist. Psychologists have a PhD or a PsyD and do therapy plus intelligence and personality testing. Psychiatrists have a medical degree, so they're trained as a doctor first, a medical doctor, and then have additional training on top of that in the area of mental issues. And they can prescribe medicine and sometimes do psychotherapy. And we also have social workers, MSW, Masters of Social Work, as well as counselors, nurses, and other professionals may be trained and licensed to diagnose and treat mental health disorders as well. That is it for the session today. We'll pick up on this a little bit later. We'll be picking up on some different types of therapy, looking at the biomedical approaches, and then we'll segue into the Appendix B, psychology applied to work, or IO psychology. Are there any questions or comments right now at this time? We good to go?
No questions here.
All right, that sounds great then. All right, so I will see you guys on Thursday for our last class as we wrap things up. That's it for now. I'll talk to you guys later. Have a great day.
Thank you.